Welcome to the webinar. I'm Lauren Stiles, President of Dysautonomia International. We're pleased to partner with the Mastocytosis Society to bring you tonight's webinar featuring Dr. Andrew White, an immunologist at the Scripps Clinic in Southern California, and Dr. Jonathan Bernstein, an immunologist from the University of Cincinnati, who is also very active with the Mastocytosis Society. They're both really excellent physicians and researchers, and we know the patient community really respects them, so we're very glad to have them with us this evening. With that being said, we're going to jump right into it. Dr. White is going to go first, then Dr. Bernstein is going to present some slides, and then we're going to do Q&A towards the end. The whole time during the webinar, you can ask questions. On the left side of your control panel, there should be a little tab that says questions. If you pop that open, you can type in a question. There are hundreds and hundreds of people on the webinar tonight, so we probably won't be able to get to every single question. And some people have emailed in questions, but we'll try to answer the more common questions that we're seeing. And we also want everyone to know that if you registered for the webinar, whether you attended or not, you will all receive an emailed copy of the webinar. And the webinar registration closed up faster than we expected because so many people registered. This is clearly a hot topic. So we've invited people who weren't able to register for the webinar to sign up for the Dysautonomia International email list so that we can email them a copy of the webinar video, which they can always do on our website, where there are links on our Facebook page as well. All right, here we go. The first speaker will be Dr. White. I'm going to change over the slide so that you can see his screen.
All right, is that working, Lauren? Oh, here we go.
I just clicked it. There you go. Make your slides full screen.
So, is that working?
No, that's presenter view.
How do I not do presenter view?
You know what? It's probably fine if you do presenter view.
It's showing the other. I don't know if I can quickly know how to solve this. Is this okay the way it is?
Okay, it's okay. It should be fine.
Okay. All right. Thanks so much, Lauren, for the invitation. And I just really appreciate this. I think this is an issue that so many of my patients have a lot of questions about, and we really need to learn a lot more about it. So let's just dive in here. I was going to focus more of my section on talking about dysautonomia and the allergic or mast cell symptoms we seem to be seeing associated with this. Talk maybe more about this from the dysautonomia perspective, and then we'll turn it over to Dr. Bernstein, who I think is going to spend maybe more of this coming from the mast cell activation syndrome side of things. So I wanted to just start off with some of the definitions so that we're all on the same page. So what is dysautonomia? So I think most of the members out there certainly understand this. This is some syndrome associated with inappropriate functioning of the autonomic nervous system. Autonomic nervous system is the part of our nervous system that governs many of the functions that we can't consciously control. So things like digestion, heart rate, blood pressure, sweating, etc. And so we know some syndromes that are associated with this. If there are abnormalities in blood pressure or pulse, then patients may be diagnosed with POTS or some form of orthostatic intolerance. Patients that have significant gastrointestinal motility disorders may be diagnosed with gastroparesis. We frequently can see problems with temperature regulation, and then dysautonomia probably also is a factor in chronic pain syndromes such as reflex sympathetic dystrophy and fibromyalgia. So now, if this is a problem in autonomic nerves, well, what is a nerve and how is the nerve actually functioning? So we know that in general the nerves are traveling from the brain down the spinal cord. Everyone probably is familiar with this. And then what happens is in the autonomic nervous system there's a small connecting area outside of the spinal cord called a ganglia. And the nerve actually will travel into that ganglia and it intersects with a new nerve, a second nerve, and that second nerve is what's going to send the transmission out to the target organ. And there's a lot of functionality that happens inside that ganglia or inside that connection spot. And so you see here on the slide, this would be the orientation of the autonomic nervous system with the nerves coming out of the spinal cord, entering a ganglia, and then there's that connection, or what's called a synapse, and another nerve is traveling now out to the target organ. So inside that ganglia, this synapse or connection spot is occurring, and you can see here these little circles. These would be the chemicals or the neurotransmitters, and these are basically taking the signal from nerve 1, turning it into, or interpreting it and sending it out through nerve 2. And so if you've heard the term sympathetic or parasympathetic nervous system, this is really primarily assigning what is going on at that synapse, what chemical is being used. And there's a variety of things. Some chemicals you're probably familiar with, like adrenaline or acetylcholine, and at that connection spot, there can be very different actions that are occurring, both at the nerve and also at the organ, like at the heart or the gastrointestinal tract. So that's a quick view of what a nerve is. So now let's transition to what is allergy. So there's a lot of, I think, misconceptions and confusion that can come from the term allergy. Some people can use that term just to refer to something bad that happens to them. But as allergists, we're really defining this as a very specific immune event. And so this is going to be a substance that can repeatedly and immediately stimulate a mast cell. And most people are familiar with peanut allergy, so that would be a good example of it. So peanut allergy is reproducible. It's going to happen every single time. You're not going to have a time when you can eat a peanut and not have a reaction. It's going to be measurable, so you can find some evidence of this in the blood or using a skin test. And the symptoms are usually going to be typical and reproducible. So every time there'll be sneezing or wheezing or hives. So this is really what we're referring to when we use the word allergy. And we are drilling down to the mast cell. And Dr. Bernstein is going to spend quite a bit more time about how we measure and look for this. But really what the mast cell is, it's a cell that's sitting in our system in most of the organs of our body and in our skin, and it's loaded with these chemicals, many chemicals, not just histamine, and it's often involved in a lot of other functions that we don't necessarily attribute to it, but one of the main things we think of is these allergic reactions. And our mast cells have antibodies on the surface, and these antibodies are specific for things like peanut or cat or dog or whatever we are familiar with that you can be allergic to. These are preloaded onto the mast cell, and then any time that you come in contact with that protein, you can trigger through those antibodies and cause the mast cell to release its contents. Here you can see a mast cell that's fully loaded, and here's one after it's released a lot of its contents. So this is what we are really referring to when we use the word allergy. And this is probably not exactly what's happening in our patients with dysautonomia or mast cell activation syndrome. And this is why it tends to be confusing, because a lot of what patients are describing doesn't necessarily show up in this particular model. So what are we seeing in the clinic? Well, this is what I see most of the days of my clinic when I'm seeing patients with dysautonomia. I'm seeing a patient with POTS, but the patient also has these symptoms which sound like they could be allergic. Things like flushing, where the face or the upper chest is turning bright red, chronic itching or hives. Patients frequently can have episodes of sudden throat tightness or a fast heart rate. Things like drop in blood pressure certainly could be part of an allergic reaction. Diarrhea and abdominal pain, nasal irritation, things like runny nose or stuffy nose, and shortness of breath. So it's very easy to understand how these symptoms could be immediately attributed to some sort of allergic reaction or a mast cell problem, but they're happening in someone that has dysautonomia, and this really has us asking a lot of questions about what's really going on here. So what is going on? Is this really just an autonomic disorder and the mast cells kind of are playing a secondary role? Or maybe option 2, is this mostly a mast cell activation disorder and the mast cells are really kind of driving or triggering the autonomic response. And I guess the third option is it possible that all of these patients out there are unlucky enough to have two unrelated disorders? They happen to have POTS and they happen to have mast cell activation syndrome. I don't think that this third option is really probably the case, and I think we probably don't know the answer to these first two. And so when I see patients, I often will kind of see them on this spectrum. Some patients seem to really be predominantly just autonomic dysfunction. They don't seem to have a lot of these mast cell symptoms. And then some of the patients are really primarily bothered by the mast cell symptoms. And although they have autonomic dysfunction, that doesn't really seem to be what they're most worried about. So one of my first tasks seeing a patient is try to figure out where are we on this spectrum? Where should we be focusing our energy? And so that brings us back to this slide that I showed you before. We've got the mast cell here, and then we've got the nerve. And we tend to think about these as being completely separate things. The mast cell has, one function, the nerves have another function. But you can see here I made my mast cell quite small and stuck it next to the nerve, and that's probably what is happening in real life. We think that the interactions with the mast cell and the nerve are very important. It's possible that things like histamine could actually function on the nerve and get here in the synapse and act as a transmission. It's also possible that what's going on the nerve can actually trigger the mast cell. And so maybe we need to stop thinking about these as two separate things, but perhaps this is a unit, and this unit needs to be considered together. This is an electron microscope picture that shows in this bottom slide, this is A for artery or arterial, a very small artery. Here's a nerve, and here's a mast cell. And this is not an uncommon occurrence to see these three things together. And so you can really see how just the physical location of one of these could really influence the other. And there's a lot of science now that can connect these two together and show that what's happening at one is very important in the other. So here's my rhetorical question. Are all sneezes allergic? We tend to think about sneezing as an allergic reaction. Obviously, if you're allergic to cats and you go to someone's house that has a cat and you sneeze, well, that's because you're allergic, right? But we know that many people sneeze for other reasons. One of the common things that we see is sunlight. People walk from a dark room out into the sunlight and they sneeze, and that's a neurologic reflex. It has nothing to do with mast cells. And so you can see here that in some patients, a sneeze, and you'll see why I'm giving you this example in a second, the sneeze can be triggered by things that have nothing to do with allergy. It stimulates this reflex, you don't have any control over it, and you end up with a sneeze. Sorry about that. On the other side, you can have the mast cells involved. You can have a cat allergy. The mast cell releases histamine and leukotrienes and a variety of chemicals that cause inflammation, and those trigger the nerve, and then you end up with the sneeze. So in that situation, you need both. You need the mast cell and you need the nerve, not just the nerve. So what if we use the same example for POTS? So we know in POTS you can have some things that probably have very little to do with the mast cell, things like heat or overexertion or prolonged standing. And so potentially this is really more of a neurologic problem that triggers the inappropriate autonomic response. And what we don't know, but what's certainly possible, is that the mast cell could also play a role there. And so things like dietary factors or alcohol or certain medications that can trigger mast cell release could act locally on the nerve and cause that nerve to send a signal that, again, may be causing inappropriate autonomic function. And what we really don't know is, can the mast cell do this all on its own? Can just a lot of histamine in your system or a lot of leukotrienes just directly affect the autonomic nervous system and really not be, kind of a cofactor, something we need a lot more research about. So Lauren had sent me this slide about a week ago, and I think most people with mast cell activation syndrome, this probably can make your head explode. Histamine can do a lot of different things, for sure. We know that when someone's having anaphylaxis, there can be multiple organs involved and multiple symptoms that can occur. But what do we know about histamine in something like POTS? And we don't have a whole lot of evidence of really what's going on here. This is one of the only studies. It's a great study. We really need a lot more like it. So in this study, this came out of the Vanderbilt Autonomic Center. They looked at patients with POTS that had recurrent problems with flushing. And the theory was that these patients may have evidence of mast cell activation syndrome. So they found a group of patients with flushing, and then they did a urine histamine test on all of them. And they found half the group, or roughly half the group, seemed to have elevations in their histamine, but the other half of the group did not. And they compared that to control subjects. And if you're familiar with the POTS syndrome, there are different subtypes of it. One of the subtypes might be this hyperadrenergic form, and that was really what they saw in these patients that had mast cell activation syndrome. They had evidence of the hyperadrenergic form. So some important things that came out of this. Number one, not everyone that had flushing necessarily had evidence of mast cell activation. And the other is this theory here, this loop of what could be happening. So the authors thought that potentially something is triggering sympathetic activity, which is kind of our adrenaline response, our activating response. This would increase the hormones that are involved in that pathway, and potentially this is somehow causing the mast cells to become more activated and then release histamine. That may be involved in the flushing in some of those patients, but the histamine also can have further action on the neurovascular system, and you end up potentially making things worse and causing even more sympathetic activity. And you can see how you start to spin around this circle and things could go out of control. We don't know if this is the case, but this is certainly an interesting model and makes a lot of sense to most of us that, or at least to myself, as I look at this disease. So I just had a few more slides here before I finish. One of the other items that's come up a lot in my clinic is this syndrome called familial hypertryptasemia. This has been described in 2 papers from a group at National Institutes of Health. They initially described several families where about half the family members had elevated levels of tryptase. Tryptase is a protein that comes out of the mast cell. Dr. Bernstein will probably talk quite a bit more about this. Several things that we learned about this particular condition. It's genetic, so it runs in families. There's often many family members that will also have elevated tryptase. By definition, this is an elevated tryptase at baseline, so you don't have to try to stimulate it. You don't have to try to catch it during an acute allergic event. These patients have it every single day walking around. So you can answer the question of whether you have this condition very easily if it's negative. If you don't have a high tryptase, then you don't have this condition. They were able to show where the problem is, that these patients, if they have an elevated tryptase, they have too many copies of the tryptase gene. The patients did not have mastocytosis, and ultimately what they found is that in all of these people that had the elevated tryptase levels, there were higher rates of a lot of the things that our patients complain about. So a lot more autonomic dysfunction, a lot more chronic pain, a lot of gastrointestinal complaints. But what we don't know is how this is connected. We don't know what the root cause is. We don't know that the tryptase is causing the problem, or whether there's something else going on here that we don't know what we're looking for. But we know that there is at least a connection, that if you are one of these individuals who has a high tryptase level, you're more likely to have problems with dysautonomia. At this point, it doesn't really seem that doing any genetic testing for this is going to change the management at all. We're still focusing on symptoms, and so if you have this high tryptase and several other family members have it, I'm not sure pursuing genetic testing would make much of a difference. So I have 2 more slides. These are kind of my summary slides here. So what's going on? So dysautonomia probably has several causes. So I don't think we should just assume that in every patient with autonomic dysfunction that mast cell activation is a root issue. But we do know that, at least in some, these mast cell and nerve interactions are probably very important. We definitely know in animal models and basic science experiments that mast cells can trigger nerves, and the converse is also true, that nerves can trigger mast cells. We know, or I'm sorry, my theory, I shouldn't say we know, my theory is that the mast cell activation syndrome that we are referring to in patients with dysautonomia is probably somewhat different or substantially different than the individuals that we see that have recurrent anaphylaxis but feel completely well between these episodes and don't have autonomic dysfunction. We could probably appropriately refer to both of these as mast cell activation syndrome, but I think from a disease definition standpoint, they really might be quite a bit different, and really also probably quite a bit different than mastocytosis, which is a clonal problem, and I think Dr. Bernstein will go over really what the substantial differences are there. My impression is that the lab testing can help here in dysautonomia, the testing we do for mast cell activation syndrome, but it's certainly not perfect. We need a lot more work on that. And so my final slide, my take-home points would be that by its very nature, dysautonomia is a disorder that reacts. It's an inappropriate reaction to foods or medications or environment. But just because we react, not all reactions are allergic. So if you stand too long and you get flushed, that doesn't necessarily mean that you're having mast cell activation syndrome. And so we have to be careful, and I think try to be more precise in what's going on in patients when they're having autonomic dysfunction and flushing or other allergic symptoms, is trying to really tease out, what parts are related to what. It's complicated, and I don't necessarily think I have a great answer for that. And that's really the problem here. We don't understand what's happening in dysautonomia with mast cells, but in general, the impression is that at least in a subgroup of patients, really focusing our treatment on mast cells and mast cell activation can be quite helpful. And I think that's where the allergists have a big role in helping with POTS and dysautonomia. So that's all I'll have. I'll turn it back here to Lauren.
Hi. So really quickly, I actually wanted to do a poll with you guys, just a little interactive thing if you want to. You don't have to answer. But, oops, I opened the wrong thing here. I'm not sure if you can see my screen. So the poll is just asking if you've been diagnosed with mast cell activation syndrome. So you can see that it might be on the left side of your screen in the poll section of your GoToWebinar control panel. Actually, no, sorry, it pops up right on the main screen. So, well, lots of folks are answering. I'll just leave it up for a few seconds. So it looks like we have pretty much the final result. About almost 60% of you say that you have been diagnosed with mast cell activation syndrome. About 14% haven't, and about 30% of you haven't been officially diagnosed but think you have it. And I think that's probably basically what we see in the POTS community, where we see a fairly high percentage of these patients diagnosed with it, and then another subset kind of wondering if they have it or not. So thanks for participating in the poll. I have another one really quickly we can do before we hop over to Dr. Bernstein's presentation, wondering if you've been diagnosed with a form of dysautonomia. So you can answer that if you want to. So it looks like pretty much the same overlap. About 70% of patients have been diagnosed with a form of dysautonomia, about 11 or 10% haven't, and about 20% think they might have a form of dysautonomia but haven't been formally diagnosed. All right, thanks for participating, guys. I'm going to switch it over to Dr. Bernstein's slides now. 1 second. Dr. Bernstein, are you there?
Yes.
Great. Okay, the floor is yours.
Okay, well that was an excellent introduction discussion of this complex interaction between the mast cell and the nerve. What I'm going to do in the next 15 to 20 minutes is try to complement what Dr. White talked about in the context of talking more about mast cell activation and how this contrasts with mastocytosis. So here again we have a resting mast cell, and you can see when it's activated, you see the granules who are being released. In fact, we call it degranulation, but what really happens are the granules actually merge with the cell membrane and they exocytose. They release their granules and they actually then recycle within the mast cells. So they become vacuated, and then over a couple of days they recycle and can then be activated again. Now, in the situation of mastocytosis, these cells are constantly releasing their contents. So I think before we get into mast cell activation syndrome, we should be talking about what are the diagnostic criteria for mastocytosis. And these are one of the classification systems. And again, the major classification is the presence of having dense aggregates of mast cells. And again, 15 or more mast cells in sections of the bone marrow or other tissues in the body that are confirmed by tryptase immunohistochemistry, so they can stain with these different markers for tryptase to show the presence of mast cells. There's also other special stains that can be used that can differentiate mast cells from other cells in the body. There are minor criteria which include having these atypical or spindle shape appearance of at least 25% of the mast cells in the diagnostic in the biopsy, and expression of other cellular markers called CD2 and CD25 by mast cells. And these can be seen in the bone marrow, the blood, or other organs that are affected. Other criteria having this KIT codon 816 mutation, which is the mutation associated with mastocytosis, and this can again be seen in the marrow, the blood, or other organ systems, and then having this persistent elevation of serum tryptase, which Dr. White mentioned, that patients with mastocytosis have high levels at all times. They're constitutively releasing mast cells, mast cell contents, and tryptase is the marker for that. Now, there are several subtypes of systemic mastocytosis. Probably the most common is the indolent systemic mastocytosis, which may include smoldering systemic mastocytosis or isolated bone marrow mastocytosis or well-differentiated systemic mastocytosis. So it's really not important to know all the classifications or the subtypes, because these are based on just clinical and histologic criteria. The aggressive systemic mastocytosis, again, patients are much more symptomatic. And then there are these other forms of systemic mastocytosis associated with hematologic non-mast cell lineage disease. So again, these are very rare conditions for the most part. And a lot of people, when they come in with mastocytosis, are worried that they have some type of malignancy, but these are extremely rare and are not the most common type of mastocytosis that we see. Now, these are again a more updated provisional criteria that defines mast cell activation syndrome. So this is a consensus opinion based on groups who have expertise in mastocytosis, and also of having seen a lot of patients with mast cell activation syndrome. So in similar to the mastocytosis, there's the major criteria for mast cell activation was having a constellation of clinical complaints, which Dr. White talked about, attributable to pathologically increased mast cell activity. So this can be measured a number of ways, and again, when we measure it clinically to see if there's mast cell involvement, we can measure tryptase in the blood, or we can measure histamine or its metabolites in the urine, as well as other mast cell markers such as prostaglandin D2 or F2 alpha. They seem to be the best correlates. Others have looked at chromogranin A, which is more often used in things like carcinoid syndrome, but and other neuroendocrine tumors. But there's a number of different markers that one can try to measure. There's other minor criteria which are showing these abnormal spindle-shaped mast cells that we talked about in systemic mastocytosis, or having these cell surface markers like CD2, CD25. So there's a number of what this group have defined as being minor criteria. And you only, to have a diagnosis of mast cell activation syndrome, you have to have the major criterion plus any one of the minor criteria. So you don't have to have all of them. You can just have one, or you can have 3 minor criteria. So that's a pretty rigorous definition for what we talk about when we see patients with mast cell activation syndrome. Now, others have looked at it a little bit more simplistically and have, diagnosed this condition based on having typical clinical symptoms. And again, this was discussed by Dr. White, and having an increase serum tryptase by at least 20% above baseline. So if someone has a tryptase of, if normal is, 15, then they would have a level of 18 would be 20% above baseline, plus 2 nanograms per ml. Okay, so you'd have to have a tryptase of 20 to meet that criteria. And that would be within, during or within 4 hours after a symptomatic period. So unlike systemic mastocytosis, where there's less fluctuation, patients with mast cell activation, these levels can fluctuate a little bit. And then a big criteria that has been used is response of symptoms to treatments that block histamine. So histamine receptor blockers. There's also other agents that stabilize mast cells like chromalin sodium, and even using histamine receptor type 2 antagonists have been included. So this is a more simplistic criteria for diagnosis. Now, as Dr. White talked about, the symptoms that we see in patients do overlap quite a bit with dysautonomia, but typical features reported by mast cell activation patients include the flushing, the itching, hives with angioedema, congestion, nasal itching, wheezing, swelling, headaches, hypotension, diarrhea. So these are all the classic types of symptoms, but not to say that there can't be other symptoms patients report. These symptoms tend to be either recurrent or permanent. They can't be explained by other known disorders. And you can see that, for instance, congestion and itching could be allergic rhinitis or non-allergic rhinitis. In fact, we see quite a bit of non-allergic rhinitis in patients who have dysautonomia. Again, the other criteria we talked about are used to make the diagnosis. Now, these are some of the mediators that are seen, histamine and the symptoms it can produce. I think Dr. White showed a nice slide showing everything histamine can do and the organ and the outreach that it has. But certainly it can be involved in headache, hypotension, hives, with or without soft tissue swelling, angioedema, itching, and diarrhea. Prostaglandins are involved in PGD2 in terms of mucus secretion, constriction of the airways, and vascular instability where blood vessels dilate and blood pressure can drop. Platelet activating factor can be involved with abdominal cramping, hives, bronchoconstriction, drop in blood pressure, cardiac arrhythmias, and so on. So you can see that a lot of these mediators that are derived from mast cells have can cause a lot of the signs and symptoms that patients with mastocytosis and mast cell activation syndrome complain of. Now, I just want to kind of reiterate this concept of the interaction between the nerve and the mast cell, and Dr. White really described this quite elegantly, I felt. But here we can see the mast cell pictorially, that it has these Ig receptors that can be activated, but if we see that, and we can see the different mediators that can actually have an effect on other receptors. I'm not going to talk about these PAR receptors, but what I'm interested in trying to illustrate is the fact that you have other physical factors, whether it's mechanical, thermal, or chemical, that can activate nerves that release neuropeptides such as substance P or calcitonin gene-related peptide or neurokinin A that can activate mast cells directly through and release these different mediators that exert a lot of the symptoms that patients with mast cell activation syndrome exhibit. So, and I want to focus on these receptors. These are called TRP receptors, and these are ubiquitous in our body. They're everywhere. They are calcium ion channels, and they are triggered by temperatures, osmolality, chemicals, foods, and can activate nerves that can depolarize and cause a number of different physiologic effects, including overactivation of the parasympathetic nervous system, causing autonomic imbalance, but also direct mast cell activation. And it's interesting because these receptors are co-localized with a lot of receptors in the body that have a variety of overlapping clinical effects, including histamine, different cytokines, and leukotrienes and such. This is just showing the different types of receptors that are these TRP receptors and how they are activated. There are TRP1, this stands for transient potential response. The NIL-1 is activated by capsaicin. You may be familiar with capsaicin, topical capsaicin over the counter for people who have used this for pain, and actually it's working through blocking or over time desensitizing TRPV1. There are other types that respond to even hotter temperatures, and some of these other TRPV receptors respond to osmolality, cold, like camphor, as well as hypotonic cell swelling, which is a mechanical receptor. The TRPAs respond to a lot of different foods and chemicals, and whereas TRPM8 responds to cooling, like menthol and eucalyptus, again, there are other receptors that respond to even cooler temperatures. So these are in our nose, these are in our lungs, these are in our gastrointestinal tract, they're in our skin, they're everywhere, and they are the first interface between the external environment and our nervous system, so to speak. So that being said, I think, it's very clear that there is an interface between the mast cell and the nervous system, and as Dr. White discussed, it's not clear how, what is, to what degree it's affected more towards one direction or the other, but we do have these criteria that we have to adhere to for diagnosing mast cell activation syndrome. I see many patients who come in with thinking they might have this. They have clear features of dysautonomia, but we aren't able to support the diagnosis of mast cell activation syndrome because they're testing for these different biomarkers and other criteria are not, they're negative. They just aren't present. So that leads us to the question, how do we treat this? And there are algorithms that have been developed to treat mast cell activation, and one of the criteria that we talked about is that patients with mast cell activation typically do respond to the medications that block histamine receptors and leukotriene receptors and even prostaglandins and such. So those are, and then also that are stabilizing the mast cell to prevent them from activating. So the first line therapy is really involving histamine type 1, histamine type 2, leukotriene modifying agents, and mast cell activation syndrome, mast cell stabilizing agents. So what happens when this doesn't work? Then there are studies that have looked at other types of agents, immunosuppressive drugs. There are now several case studies looking at omalizumab, which is a medicine used to treat asthma and has also been approved to treat chronic idiopathic urticaria not responsive to antihistamines. And this works by downregulating Ig receptors and stabilizing mast cell membranes. But we're not clear exactly how it works in hives at the present time. There are these other inhibitors of tyrosine kinase that many of you might have heard, like Gleevec and so forth. And then there's a lot of other investigational drugs and so forth. And so when we see patients, given that we have this kind of very weak criteria for diagnosis, and we understand pathomechanisms not very well at the present time, especially how it interfaces with all of the dysautonomia. And I think one of the things that should emphasize with the dysautonomia, we're seeing a lot of migraines, and we're seeing a lot of Ehlers-Danlos syndrome type 3 patients. They seem to be clustered in this group of dysautonomia. We're left with treating symptoms, and this is really our charge based on trying to organize our thought process into the types of the problems that patients who present with these conditions, how we can hone in and treat these conditions and try to alleviate some of the associated morbidity with this condition. So you can see that, for instance, with the gastrointestinal type of problems, the types of things one might try to see if it can relieve some symptoms. And again, some of these are more aggressive therapies, and I would say that most of these are, again, not well studied and have been tried in different ways to alleviate problems with patients with this condition. I'm just going to show these next several slides because this table really is the therapies that we use most commonly for patients with mast cell activation syndrome, as well as mastocytosis. As I mentioned, H1 antihistamines, and preferably second and third generations because they cause less sedation and less dryness and gastrointestinal symptoms, because they do have an effect on preventing the physiologic effects of histamine on the receptors that they bind to by blocking the receptors. And then the H2 antihistamines, which actually may work synergistically with the H1s by enhancing their response. They also, when histamine binds to histamine type 2 receptors, there's a number of physiologic effects that occur. Leukotriene receptor antagonists are also very important in this model by blocking the leukotriene receptors, and chromoline sodium, also known as gastrochrome, especially for gastrointestinal symptoms. But we have had patients who've used the inhalational chromoline sodium, more so with mastocytosis, that have actually gotten some benefit, and they do make topical nasal sprays. So it does come in different forms, inhalational in the nose, the lungs, as well as in the gastrointestinal tract. And then there's people have used vitamin C and found that has some benefit. I've been less impressed with that in my experience. This next table is talking about more second and third line therapies. Again, these are more immunosuppressive type agents. Also included in here are the lipoxygenase inhibitors, Xyluton, which blocks 5-lipoxygenase that prevents leukotriene formation, but also montelukast, which blocks leukotriene receptors. Many of you might be familiar with this in terms of, it's called Singulair and so forth. So we try to limit these types of therapies because they have a lot of toxicity. And one of the things I've personally have found in patients with these conditions, they tend to have a lot of food as well as drug intolerances. So if there's a limited ability to use a lot of these therapies due to their side effects and toxicity. But again, a number of drugs, these tyrosine kinase inhibitors, have been used. They typically work best in patients who don't have this 816 mutation, which is the classic c-KIT mutation. They work in other types of non-c-KIT mast cell disorders. They are generally well tolerated, but they're very expensive drugs and they're hard to get approved, and so there has to be good rationale for using them, especially in the mast cell activation syndrome cases. We certainly, depending on the patient's presentation and their severity, these are drugs that have been tried. A number of other, I think it's important just to show that there is a number of drugs that patients might be taking for other conditions that can actually activate mast cells. And this is just a list of things that people might be on that might aggravate their underlying condition. So it's one of the things as clinicians we have to do is to review medications and to see are there therapies that can make the underlying condition worse, and if so, can they be discontinued and see if they have an impact on the overall outcome of the patient. So I think what we have touched upon tonight is that we have these syndromes, these complex unexplained syndromes of dysautonomia and mast cell activation syndrome. There is overlap. There are criteria that have been used to make the diagnosis of mast cell activation syndrome. Certainly for dysautonomia, there are tests that have been advocated to demonstrate whether someone has POTS or whether someone has some of these other associated conditions that are representative of dysautonomia. So I think that's very important that as clinicians we try to organize as much as possible these conditions and communicate what we think is really going on to the patient so they aren't confused about what's going on and end up running around to multiple doctors trying to figure out what's going on with them. So it's our charge as clinicians to really help educate other clinicians as well as patients about how we should be thinking about these conditions. And I think if we have clear phenotypes or ways of characterizing patients with these conditions, it's going to lead the way for more research to understand mechanisms and develop more effective, specific, selective therapies that can help patients suffering from these conditions. This last slide just basically shows some of the issues raised by patients both in the United States and Europe, and there's a uniform request that there's better access to care from physicians who have knowledge of mast cell disorders and more specialized centers, and this would include having better definitions and criteria for mast cell activation syndrome, having more curative therapy rather than just treating symptoms. This goes towards this idea of research and having funding to really study this condition in better detail, and developing better practice parameters for diagnosis and treatment, and to help access medicines that may not be available in the United States for patients with this condition and so forth. So, and I think that one of the comments is having a more holistic care plan to address not just specific symptoms, but the total patient, because multiple organ systems are typically involved here. So I think that there's a lot to do in this area. We have really just begun to scratch the surface. I think even with mastocytosis, systemic mastocytosis, we really haven't come that far as we would have liked to really find effective treatments to cure this disease. And now we have these variations, mast cell activation syndrome, morphing with dysautonomia, and this is going to make this is even much more complex, I think, at this point to investigate. But I think the future is bright because there is now more clinicians, more institutions that are are involved in the management of these patients, and this usually leads to more interest in funding research to develop better understanding of mechanisms and treatment. Thank you very much.
Thank you both so much for your talks. We're going to go through the questions as quickly as we can, so sometimes I will say which question the doctor is for, and otherwise you can both take turns chiming in as you feel appropriate. So the first question is, Dr. Bernstein, you can leave the question slide up. That's a good one since we're doing the questions. The first question is, if a patient wants to take vitamin C, what would be the ideal dose to start with?
Well, I don't believe in using the high doses. I think just using the recommended daily allowances. I know some people like to give large quantities, but I do recommend that you know, if any vitamin can be good, but too much, any vitamin and too high of quantity can be potentially toxic. So I would recommend starting off with recommended daily allowance. There are doctors who are pushing, you know, 3-4 times the amount, but I wouldn't. I don't advocate that.
Okay, and the next question is, which is preferred, oral cromolyn or inhaled cromolyn, and is there any reason you lean towards a certain choice on that?
Well, for mast cell activation syndrome and mastocytosis, the patients have a lot of gastrointestinal symptoms, and a lot of times, you know, patients undergo gastrointestinal evaluations by their GI doctor. They get colonoscopies, they get esophageal duodenoscopies, and they get biopsies, but these they're not biopsying, they're not staining for mast cells. So if you've had one of these procedures and the doctors are not, they're looking for typical things, they're not looking for mast cells, they should go back and have these specimens stained to see if there are mast cells. Many times there are more than the normal levels of mast cells in these tissues in the patients that we see. So if there's gastrointestinal involvement, the oral is best because that's going to go down into the gastrointestinal tract. It doesn't get systemically absorbed. It's actually very poorly systemically absorbed, but it definitely works at the surface of the gastrointestinal tract to help stabilize mast cell membrane. So that can be very effective. We've seen in some of our systemic mastocytosis patients, the inhalational forms, nebulized forms have helped actually control some of their respiratory symptoms and so forth. I haven't seen as much of an effect in our mast cell activation unless they have respiratory involvement, then I would use that. So I would target that to the organ systems involved.
Okay. This question was back from Dr. Whiteslides. How common is familial tryptasemia?
That's a good question. I don't think we can really answer that because the studies are not done in any sort of population, so you don't have a denominator. We're not saying we're going to look for this in 1,000 people. It must not be completely rare because I think in their second follow-up study there were around 80 families or so that they had identified, and I've found this twice in the last couple months. But the opposite is that we check tryptase in almost every single patient, and it's rarely elevated. So, you know, the vast majority of people that have dysautonomia and even really mast cell activation syndrome, we see a normal tryptase, and if you have a normal tryptase, then you don't have that condition.
I just want to add to that, just from informal conversations with Dr. Brent Goodman, who runs the autonomic lab at Mayo Scottsdale. He had done some research abstracts presented at conferences, but not published as full papers yet, looking at various mast cell biomarkers in POTS patients. And he told me by phone, you know, that probably less than 1 in 500 or 1 in 1,000 POTS patients had elevated baseline tryptase. So he didn't think this was very common, but I'm sure there are some folks out there that have it. The next question is, this is sort of a more generic question, you know, what's the most effective treatment for dysautonomia? And just to sort of clarify for everybody, dysautonomia itself is not a real diagnosis. If your doctor has said you have dysautonomia, you should go back to that doctor and say, what type of dysautonomia and how severe is it and which part of my autonomic nervous system? Because dysautonomia is an umbrella term, like infection is a big umbrella term that includes a lot of different types of infections. And if your doctor said, hey, Lauren, you have infection, you would want to know, where is it? How bad is it? Is it treatable? You know, what kind of infection? So try not to use the term dysautonomia as if it's its own diagnosis. There are different effective treatments for different types of dysautonomia and also for people who have different underlying conditions. So there's really no clear answer on the most effective treatment for dysautonomia because it depends on which type you have. Sorry, I answered that question, guys. The next question for you guys. Dr. Bernstein, can you discuss the toxicity of Singulair?
Well, Singulair is pretty well tolerated. It has relatively few side effects. There are some cases where patients feel like it makes them a little depressed sometimes. I've had a few cases of that, and that's been reported. But this is a drug that's approved for babies through adulthood, so it has been studied quite extensively and is used quite commonly in the treatment of asthma and allergic rhinitis. So I think overall the toxicity is extremely low and benefits outweigh risks. Now, is it always going to be effective? That's the question. There is a drug called Xyluton, which is a 5-lipoxygenase inhibitor that actually it works higher up in the cascade, in the leukotriene cascade. So rather than blocking receptors for leukotrienes, that's what Montelukast or Singulair does. This actually prevents the 85% of the production of leukotrienes. It doesn't completely block it, but it blocks most of what the production of leukotrienes. And so that could have a good bit of effect, and that's actually been the question is, would it work better than leukotriene receptors? But either one, we use them both. And the Xyluton does have a little more toxicity. You have to monitor liver function after the first month and then occasionally thereafter. So, but it's, again, overall safe medicine as well.
Can someone have few allergic reactions in general, but if they have a sun allergy, would you think that that might be mast cell activation syndrome, or would you be thinking about other things? This person says in the sun they get hives, rashes, and redness, but not allergies in general.
Yeah, that sounds more like solar urticaria, which is a form of physical or inducible hives. There are other types of reactions that can occur in sunlight, like photodermatitis, especially if patients are taking certain medications that make them more susceptible to that, like sulfa drugs or something of that nature. So that sounds more like solar urticaria, which is a rare form of physical hives, but and can be challenging to manage. And I think an allergist, they should see an allergist who treats urticaria. But certainly, if someone's working outdoors in the sun, this can be a problem.
Yeah. Can someone take too much Benadryl? I know the answer is yes, but why don't you guys elaborate on that?
I'll answer that because I've just had a patient that has had trouble with that. So yes, absolutely. The problem with Benadryl, one of the problems with Benadryl is that it has the side effects everyone's familiar with, dry mouth and sleepiness. And those are related to effects on the cholinergic nervous system, which is actually part of the autonomic nervous system. And so it is certainly safe at reasonably high doses, but if you really push it, there's a chance of causing even potentially some mental confusion or things where the patient may not be thinking properly, and people can be worried that they're having some sort of medical crisis. You could also have a lot of side effects like dry mouth and gastrointestinal symptoms potentially. So I think in general it's very safe, and we know for sure with long-term use at reasonably high doses it's very safe in our chronic hive patients. but there's certainly a limit, and you should be talking to your doctor about kind of where that ceiling is, because probably at some level you're not going to be getting any additional benefit, and you're just going to be asking for side effects.
Can someone have altered prostaglandin D2 readings on a 24-hour urine test if they're on oral birth control pills?
So they're altered in what respect, like high or low?
I guess just doesn't alter the results.
Well, I don't think that has much of an impact. I mean, certainly we do know that hormones can have an impact on mast cell activation. There are conditions where progesterone can act. In some patients can become sensitized to progesterone compounds, and there are hormonal receptors on mast cells. But in measuring prostaglandin, I don't believe there's any effect on getting accurate levels of prostaglandin D2 or F2 alpha if you're taking birth control.
So that is a perfect lead into the next question, and this was asked by someone else, but I'm seconding the question. This person notices that their mast cell flares seem to correlate to fluctuations during their cycle. Do we have any research proof showing that mast cells sort of behave differently in different parts of the different times in the menstrual cycle in relation to different hormone levels?
Well, again, progesterone hypersensitivity is a prime example of that, where typically women, where they experience hives, but they can also get other types of rashes that typically begin a few days before the beginning of the cycle and then typically start to subside a few days after the menstrual flow begins, but it can continue throughout the cycle. And so this has been well described. It used to be called autoimmune progesterone dermatitis, but the idea of autoimmunity, there's not a lot of mechanistic support for the autoimmune response in this condition. But that is, again, an example where patients become sensitized. They develop allergic antibodies to progesterone, similar to what Dr. White was talking about earlier, which is a different pathway than what we're seeing in a lot of our mast cell activation patients and our dysautonomia patients. Not to say there can't be overlap and these conditions can't exist, and it certainly should be considered, and that should be part of the history in these patients.
Do you see a male or versus female sex differences in mast cell? Is it more female predominant, or are the symptoms different in different sexes?
I mean, Andrew, do you want to speak to that? In my experience, I see more women, but
I would say that's true as well for me, but I think I'm probably biased by the amount of patients with dysautonomia, and since that group seems to also be, especially our POTS patients are much more likely to be female.
Yeah.
I don't know of any good population studies, though, on non-mastocytosis MCAS.
Right. Yeah, we're really limited on the type of data. There haven't been large, prevalence studies and demographic studies at this point. I think that's something that's widely needed to get a handle on this condition.
Yeah. Do you hear of patients having unusual reactions to cromolyn? So this person is saying that it caused an exacerbation of their mast cell symptoms each time they took it.
I have had patients myself who've said they didn't tolerate it, that they felt they got worse, or they just got nauseated from it, and they just couldn't tolerate it. So why that's happening, it's not entirely clear. I mean, gastrochrom's cromolyn sodium is a very safe drug. It's been around a long time. I see a lot of patients who are showing up taking quercetin, which is actually the root compound of cromolyn sodium, which was originally derived from quercetin. So, but cromolyn sodium is a more refined structure that has mast cell stabilizing activity. So yes, it does happen, and I think that also speaks to the fact that there are a lot of these mast cell activation syndrome patients have a lot of drug intolerances, in addition to food intolerances that can make it more challenging to manage.
The next question is, when a mast cell attack happens, can someone have sort of neuromuscular twitches or tics?
I would say that is not a traditional symptom that most of us allergists would say would be kind of a typical allergic symptom. But I've seen that in many of my patients. All of them, I think, have a co-diagnosis of POTS or dysautonomia. I don't think I have a good explanation for that in terms of whether that's really a mast cell problem or an autonomic problem. I would just put that in a kind of perplexing category that I've seen in some patients, and I don't know how to explain it. I don't know if Dr. Bernstein has an opinion.
No, I would agree. I think that there's a lot of, even though we talked about certain common symptoms that patients present with, there is a spectrum that I think we've collectively seen, and this is, I would agree, one of those that's a little more difficult to, understand. I mean, again, there are a lot of patients who come in. They have muscle spasms. They have, maybe some of this could be these twitches that they're experiencing. Using neuroleptics have been used to some extent. That people have been on drugs like gabapentin to help treat some of these issues, or amitriptyline with some effect in some circumstances, as well as the headaches and some of the other symptoms that they present with. But mechanistically, I don't understand why that's occurring.
So I want to be respectful of your time. We're supposed to wrap up at 9, but I just want to get 2 more questions in because I think they're pretty good. Someone's asking, what's the difference in the definition between mast cell activation syndrome and mast cell activation disorder?
I think that they're pretty synonymous. There's a lot of terminology that's going around and reclassifications, and but in that situation, I would use those terms interchangeably.
Okay. The last question, I think, unless you guys want to take more time, but I promised you an hour, and we're a little past. Do you see an increase in autoimmunity in your mast cell activation syndrome patients, particularly within the dysautonomia population? And whether or not you see that increase, is there any research suggesting that mast cell activation syndrome may have an autoimmune connection?
I think we look for that. I guess I'll answer quickly. I think we look for that and think that that's a possible mechanism that may connect these disorders, some sort of specific autoimmune issue. But whether there's more systemic lupus or rheumatoid arthritis in our straight-up mast cell activation syndrome, I'm not sure that I would say that there is, or that I've noticed that. I think it's a different story when you're looking at it maybe from the dysautonomia side of things.
Yeah, I would agree. I haven't seen a strong predilection for autoimmune disorders. Now, that being said, there have been other common conditions that we see, like urticaria, which is hives, and there is a large percentage of patients who have positive tests that suggest an autoimmune condition. But again, we don't understand the clinical relevance of that, whether it's really involved, mechanistically and causing hives. In other words, we might see a higher predisposition for thyroid autoantibodies or rheumatoid factors or ANAs, anti-nuclear antibodies, but we don't understand the clinical relevance. And I suspect that, we haven't really looked at this to any great extent in these populations, and even if we find these, there might be a higher predominance. That doesn't mean that there's a cause and effect and that there's a functional relationship. So it's still, the verdict is out.
Right. So with that being said, I wanted to add very briefly to that Dysautonomia International had put out a call for POTS research proposals on November 1st, and I'm really excited to announce that we received over $2.2 million in requests for POTS research funding for grants of $100,000 or less. We received 32 applications, and some of them were related to trying to understand the relationship between POTS and mast cell activation syndrome, POTS and EDS, POTS and EDS and mast cell activation syndrome, all the various flavors that our patient community comes in. There are people interested in researching this and trying to figure it out. And if you're listening out there and you're really struggling right now, I want you to sort of hold on to that hope, because there are people trying to help us. I hope that everybody enjoyed this evening's webinar. Thank you so much to Dr. White and Dr. Bernstein for your time and your expertise. And thank you for being doctors that are interested in these complicated patients. I think that's it. We're going to sign off. Thank you so much for your time. Good night.
Thank you. Good evening.
Good night.